Thank you. That's quite a hard act to follow. That was a great epilepsy talk, wasn't it? So I don't know how many of you know from Jenny on the stand over there for PCS. It seems really mixed as to whether people know that we are running a women's health hub for menstrual and menopause problems. So you can refer in, see if I can get to my first slide. So I am a GP at Porterbrook and I've been there for years and years, but I have a specialist interest in women's health and particularly in the menopause, which is why I'm in this role. And the hub started in March of this year. It's being funded by Women's Health Strategy money. So there were small pots of money given to each ICBs across the country. And there were some core specific areas that needed to be met. So it was looking at the areas of gaps that we had. And in Sheffield, it was that although there's really good provision for treatment of heavy bleeding with Mirena fits, things like that, there was a bit of a lack in assessment. And alongside that, we all know that there are really extended waits to be seen by gynecology. For the menopause clinic, I'm not sure exactly what it is at the moment, but it's around up to a year to be seen. And for gynae, obviously, it very much depends on the urgency that you've identified in your referral, and then gynae have triaged that. If you refer via cases, anything which is felt appropriate to come through, which is either a menstrual issue, so heavy menstrual bleeding, painful periods, or menopause, will be diverted through to the hub if it's felt that it's appropriate by the cases reviewers. There is menopause is my specialist area, so for that I'm doing MDT with the menopause clinic as well, so that we can all discuss the complex patients that come through if we don't feel that we can manage without discussion with each other. And I have gynae supervision from Miss Madhavrata, so if there's anything that I'm not sure about or anything that I'm not sure about the urgency of referral, then I'll discuss that with her. And a real bonus of that means that referrals are hopefully being seen in a more timely way as well, because they can very much say, yes, we want to see this person within 6 weeks to do a hysteroscopy, or no, we're happy for them to wait 20 plus weeks to be seen. It is, hopefully it's running quite well at the moment. It's had a really significant impact on referrals into secondary care. Most patients are seen for a first appointment within 6 to 8 weeks, which is obviously considerably less than secondary care. There are slightly longer waits for follow-up, and where I can, I'm trying not to arrange follow-up unless the patient is quite complex. I'm trying to write letters out to you that might seem overly detailed if you've been getting them, but it's to try to provide a little bit of advice on what might be helpful for you in the future with similar patients, but also to give a plan going forward if what I've instigated isn't working. One of the downsides to it is that it works in a very similar way to out of hours. And at the moment, this is a pilot clinic, and the way that it's set up means that I can't do onwards referrals. So if someone does need a referral onto gynecology, if that's a 2-week wait, I'll complete the form, much like happens in extended hours. If it's an onwards referral to gynae, then I will do or to another specialty, I'll do the letter, so that all that you have to do is to send that on, because obviously no one needs more work in general practice. Results should all come back to me, so scans should come back and any bloods that I've ordered, but we have seen sometimes, and some of you will know, that those results, for whatever reason, the lab have sent back to your practice rather than back to me. If that happens, I'm really sorry, we don't have any control over that, but if you don't know what to do with the result, if you can email it through to sexual health, and then we will deal with that for you. The only thing that I would ask is, please don't task me. So I'm only in clinic once a week, and those tasks won't be seen, and obviously if I'm on annual leave. And I have had tasks which have been about patients who required a 2-week wait from a scan result. So it is really important that you don't task me, but anything that you've got any queries about, if you email it through to sexual health, if I'm in clinic within 24 hours, I will pick it up. Otherwise, the cases reviewers would deal with that, and you would get a response as to what should happen, or we would deal with that. So what I am going to talk about today is I've tried to pick up the most common themes that are coming through clinic. So if there's going to be a real mixed bag in the audience, isn't it? There might be some of you who feel that you know absolutely everything there is to know about HRT prescribing. I can see some of you on the back row. So you're free to just check your emails, do whatever you want while I'm talking. But there might be others of you who feel that there are bits of this that would be helpful. So I'm going to talk about HRT regimes, how to choose those. Bleeding and more bleeding, because that's what we're all seeing with HRT, and that's a really strong focus of what's coming through. Looking at women with a family history of breast cancer and how concerned we need to be, who needs a referral, who can have HRT, genitourinary symptoms, and then thinking about younger women starting on HRT. So HRT regimes, and as I said, this might seem very basic, but there have been some patients coming through who potentially are not on the right types of HRT. So one of the first decisions that you need to make is, can they have estrogen only, or do they need combined estrogen and progestogen? Now, that is going to be the vast majority of women, because anyone with a uterus absolutely needs progestogen. So, but what's important is that we don't look at everyone who's had a hysterectomy and assume that they are okay to have estrogen only, because so when you see patients who've had a hysterectomy, it's really important to look in the notes or ask them what their hysterectomy was for, and did they have a total hysterectomy, or is it a subtotal? So for people who have had a total abdominal hysterectomy and it wasn't for endometriosis, it was for something like heavy bleeding or fibroids, they can have estrogen only. For anyone that's had a subtotal, we need to give them a progestogen challenge to make sure that there is no residual endometrial tissue in the cervical stump remaining. So there have been a couple of women who've come through who are on estrogen only and are bleeding after a subtotal hysterectomy. So for those of you that don't know, a 3-month progestogen challenge is exactly what it sounds like it would be. For the first 3 months of HRT, you need to give them a sequential regime. So exactly as you would do to someone who is still having periods, they're going to use their estrogen all of the time and their progestogen for 2 weeks of the month. You do it for 3 months so that you give the tissue a really good chance to bleed. And if they have any bleeding within those 3 months, you know that they need combined HRT. So that's the approach with women who've had a subtotal hysterectomy. And then the other group are women who've had a hysterectomy for endometriosis. So to have a hysterectomy for endometriosis, it can be assumed that you have got pretty significant widespread endometriosis. And there may well be residual deposits remaining despite surgery. And if we then give estrogen on its own, it can reactivate those deposits, so leading to symptoms. But it could also, in the long term, lead to malignant change, because it's unopposed estrogen in exactly the same way that would act on the endometrium. So important to just ask those questions about hysterectomy. Anyone else with a uterus needs a progestogen, and that includes everyone on progestogen-only contraceptives, apart from, obviously, the Mirena coil or any of the 52 levonorgestrel coils, because they don't provide adequate endometrial protection, even if someone is completely amenorrheic. So just thinking about those regimes. And then the next decision that you're going to make is, are they going to be on a cyclical or sequential, whichever term you prefer, or do they need continuous combined? Now, that's often thought about in terms of, are they perimenopausal, are they still having periods, or are they menopausal? So someone is defined as being menopausal, aren't they, when they've not had a period for the last 12 months. So anyone who hasn't had a period in the last 12 months would go on to a continuous combined, or what was previously known as bleed-free HRT. Anyone who has had a period within the last 12 months is going to need a sequential regime. And that's not because continuous combined would be dangerous in any way, but their own endogenous ovarian activity is going to take over with that, and they are going to bleed. And that then makes it very difficult to know who needs investigating. So giving perimenopausal women, sequential HRT is so that we know that they are going to have an anticipated withdrawal bleed, that we're not, if we put them on continuous too soon, they're just going to have irregular bleeding, and then that ends up with investigation. All women will need swapping over to continuous combined HRT at some point, and that needs to be within 1 to 5 years. At 5 years, we know that there is an increased risk in endometrial cancer for women who have been using prolonged sequential HRT. So if you've got women over the age of 45 starting on HRT, you need to make sure that you are swapping them over to a continuous combined regime within 5 years. But what's really important is I've seen quite a few women who the understanding has been that after 1 year they should be swapped to a continuous combined, or you should be trialling that. And the problem with that is that perimenopausal women, it's difficult to know where are they in that transition. And if you've got someone who is, say for example, they're 45, they're having fairly regular cycles, there's been a bit of a change to that, they've had a few symptoms, they've started on HRT, it is very unlikely in a year's time that they are going to be menopausal and ready to swap over to continuous combined. So thinking about the woman in front of you and what her periods were like before she started on HRT. But when we think about it as being perimenopausal or menopausal, sometimes there's a bit of confusion with younger women who you might presume are perimenopausal, but they're not having periods because of progesterone-only contraception, or perhaps because they've had an ablation or something like that. But it's not actually about the stage of the menopause, which method you choose. It's all about the bleeding. So if they are amenorrheic for any reason, they can have continuous combined. If you've got someone who's had an ablation, you don't suddenly want to start trying to make them bleed. And for some women, sequential HRT, the withdrawal of progesterone will always make them bleed. And similarly, for women on progesterone-only pills who are not bleeding, they don't want to bleed. We don't want to make them bleed because, again, it's then difficult to know, do they need investigating? So anyone who's not bleeding, give them continuous combined. There is really good guidance if you're not familiar with starting regimes or you're unsure about what to do with the patient in front of you. So the Primary Care Women's Health Forum, which is actually now the Primary Care Women's Health Society, has got a really good document on prescribing HRT. But there's an even handier, anybody who's got their phones out now, there's a really good app that's been developed. I think it's by UCLH, but it's called CliniBee. And that on there has a menopause section, and you can click through. It'll talk about non-complex prescribing. It talks you through all the different choices that you could make, who needs sequential regimes, who needs continuous. So that's really, really helpful, and it's really user-friendly, and anyone can download it if you're a healthcare professional. So bleeding on HRT. So I'm sure lots of people are seeing bleeding on HRT, and there are some reasons why we're seeing more of that now than we used to. So one of those is because there has been a huge increase in prescribing over the last 5 years. So obviously we've got more women on HRT, more of them are going to bleed. But the other reason is that we are using a lot more transdermal estrogen and micronized progesterone. So they are, within the last few years, the most commonly prescribed HRT items, estrogel and micronized progesterone. In fact, the prescribing of micronized progesterone over the last couple of years increased by 125%. And what micronized progesterone has in being well tolerated, potentially a little bit more breast friendly and heart health friendly, it doesn't have in good bleeding control. So lots of women on micronized progesterone will be bleeding. And the other part of it is that having transdermal estrogen and micronized progesterone has opened up HRT being available to women who it wasn't before. So women with elevated BMIs, women with hypertension, women with diabetes, all of whom are women who are more likely to bleed because those are risk factors for bleeding. So there's lots of reasons why we're seeing more bleeding. But it is incredibly common And for most women within the first 3 months, they may well experience some unexpected bleeding. So for women on continuous combined, up to, well, beyond 3/4 of women will report irregular bleeding within the first few months. After 9 months, that reduces to about 10% of those women, but it is incredibly common. So it's important. One of the most important things that we do is that we warn women that there is the potential for them to bleed. And I'll always say to women that it might be spotting, it might be like a full period, but just, one of the reasons for that is so they've got some period products at home, but so that they're not panicking and aren't needing to come back and see you before the first 3-month review. For women on sequential HRT, it's really varied who will report irregular bleeding. The stats are between 8 to 40%. 85% will have a regular withdrawal bleed towards the end of the progestogen phase. And the important part in that sentence is towards the end of the progestogen phase. So I've had a reasonable number of women referred in who there is a concern because they are bleeding regularly once a month, but their bleed doesn't coincide with when the progestogen has been withdrawn. And that doesn't really matter. As long as they're not having bleeding any more frequently than every 3 to 4 weeks, we don't need to worry about it. What's usually happening here is just that their own ovarian activity is kicking in before the progestogen's been withdrawn and they're having a bleed. So as long as it's no more frequent than once a month, then we don't need to be concerned about those women. So there is good guidance out there on how to manage bleeding. I'm not going to go into this in too much detail, but the Sheffield guidance does alter slightly from, there was a big joint guidance produced by the British Menopause Society, the FSRH, RCOG, and the Sheffield guidance does differ slightly. So it is important that we are using the Sheffield guidance to make sure that you're referring women in the right way. A key difference is that the national guidance doesn't differentiate by age, whereas the Sheffield guidance does. So if you are over 60 in HRT, you are going straight for a 2-week wait if you meet the criteria. If you're under, you would be going for a scan, and that differs slightly. So just making sure that we're following the Sheffield guidance. So this flowchart here gives a really good guide as to what point you need to investigate, what investigations you need to do. But what I wanted to concentrate on today, because that's actually really clear to follow and is on the press portal, was what we do when people are bleeding within an accepted time frame. So that would be within 6 months of starting HRT or 3 months of a dose change, or that they've been to gynecology or they've had a scan and their investigations are normal. Because the really key part here is that if we don't do something to stop the bleeding that they're having, these women cycle round and round having ultrasound scans, hysteroscopies, and the bleeding probably isn't going to stop unless we do something about their HRT. So once you have had a normal ultrasound scan back, or they've had a hysteroscopy and it's normal, or you're seeing them for their first 3-month review and they're telling you that they're having irregular bleeding, make a change then, so it hopefully stops them needing to go on and have further investigation. So this is the national guidance, and within there is a really good section on changes that you can make to their HRT based on whether they're on sequential or whether they are on continuous combined. Some of the documents from the British Menopause Society sit behind a member wall, but this one is freely available for you to have a look at. So just looking at what I would do if I saw someone who was bleeding. So the very first thing that I would do is find out about how they are taking their HRT, because that's really important. Are they taking it as you have prescribed? So sometimes that's really easy. If they're taking a tablet, it's really easy to go through taking the right part of it on sequential. It'd be really obvious which tablets are estrogen, which ones are estrogen and progestogen, and it follows on naturally. But things like transdermal estrogen and micronized progesterone are not quite so easy. If you open up the BNF and look at the licensed dosing, it's quite confusing for us as clinicians to prescribe. So for patients, I think that's even trickier, obviously. As a rule of thumb, for micronized progesterone, although it's not licensed, it's much easier to tell women to take their progesterone every night if they're on a continuous regime, or for 2 weeks out of every 4 on a sequential regime. So the licensed regimes for continuous are days 1 to 25 with 3 days off, and for sequential it's days 15 to 26. But that creates all sorts of issues. People forget that it's only 3 days off and they extend that to 5 or 7 days. That isn't helped by the fact that a packet of micronized progesterone has 30 capsules in, so understandably you would naturally take it for 25 and then miss 5. I don't know how that works. Or with the sequential regimes, people wait to get a bleed to then count their 15 days. And what's really important is that they are getting between 12 to 14 days of progesterone within a 28-day cycle, so not within whatever irregular perimenopausal cycle they've got. Everel Sequi is another place where things come unstuck. So I don't know if you've ever looked inside the packet of Everel Sequi, but it has 2 weeks worth of Everel patches, Everel 50, so just estrogen. And the other 2 weeks worth of patches are Everel Conti, so the estrogen and progestogen. But if we don't tell patients that that's what's in there and how they need to take them, so estrogen changing twice weekly for 2 weeks and Everel Conti changing twice weekly for 2 weeks, women often pluck out whichever patch is at the top on the box, and that leads to irregular bleeding as well. So the first one is, are they taking it as you've prescribed? Are they compliant with it? Are they taking enough of the progesterone? Have you seen that they're picking up lots of their patches or gel, but they're not really requesting much of the progesterone? Are they on the right regime for them? So going back to, have you got someone on continuous combined that should really be on sequential? Have you got someone who was amenorrheic with their progesterone-only pill and now they're on a sequential and bleeding? And have they changed their estrogen dose? So there are lots of social media forums out there with women and menopause influencers advising each other on what to do with their HRT. And so you might find that you've prescribed 2 pumps of gel, but your patient is actually using 6. Or that you've prescribed a 100 microgram patch, for example, and they're using 2 of them at a time. It is really easy to buy HRT online from pharmacies with no real scrutiny, so checking that they're not getting estrogen from anywhere else. One of the most important things after that, after you've checked their regime, is to examine them. And I know that it takes time to get someone up on the couch, but we need to make sure that we're not missing another cause for their bleeding. And really that means looking at their cervix. So there have been cases where women within Sheffield, where women have been scanned for bleeding on HRT, they've had changes made to their HRT, and then further, the scans have been very reassuring because it's only looking at the endometrium and the other organs in the pelvis. What it's not looking at is the cervix, and there have been cases of cervical cancer. So it's really important, if someone is bleeding, to examine them. You also might see atrophic changes. That's not going to change your management if you think that they're meeting the criteria to be referred for a scan or to gynae, but you can get on and treat that, and that might be where the bleeding's coming from, but we can't take it as read that that's what's going on. So for women on sequential HRT, as I said, bleeding is often due to their own endogenous ovarian activity. So the progestogen phase, where we can, should be in line with their luteal phase. So with women who have reasonably regular periods, getting them to start their estrogen on the first day of their period and then adding in the progestogen 2 weeks later gives you your best chance of them getting in sync from the very beginning. If you see someone at 3 months for a review, and actually that's not what's happening, they're having a couple of bleeds a month, maybe one that's just a bit of spotting and then another bleed, it might be that they're completely out of sync. So trying to look at when their last bleed was and then adding in the progesterone 2 weeks after that. That's okay if you miss a week here or there. In the very short period, that's not going to have a big impact, being without your progesterone for 2 weeks in a 28-day cycle, but you do want to try and sync it if they're having irregular bleeding. If you've got someone who isn't having a regular cycle at all, but they have had bleeds within the last 12 months, so you know they're perimenopausal, you're going to start their HRT whenever. You're not going to make them wait for a period because they may never have a period again. But they're the ones that are more likely to have irregular bleeding and you might need to do a bit of fiddling with. But they are absolutely the sort of women that if you just think, I don't know what's going on with this or how to resync it, send those through to me. Changing the dose or the type of progestogen is often helpful, so either increasing the dose or swapping to something which is better at bleeding control. So as I said, micronized progesterone is not great at bleeding control. The more old-fashioned norethisterone, Provera, the best choice would be to have a Mirena coil, but they are much better at bleeding control, so thinking about those. You can think about changing the duration. Now, it would be off licence. Most of these changes are off licence. But you could extend it rather than 2 weeks out of every 4. Some women do better with 3 weeks out of every 4, and it just stabilises the endometrium a little bit better. And often what is really helpful, especially in early perimenopause, is trying to suppress their own ovarian activity. So adding in a POP alongside, so you could add in some desogestrel, and that might be really helpful. Or in younger women, don't forget that the combined pill is a really good way of giving HRT because it gives them a really good high dose of estrogen, it suppresses their natural cycle. And one of the biggest problems in perimenopause isn't actually always the low level of estrogen, it's the fluctuation. Particularly with things like anxiety, it's the fluctuation that seems to trigger rather than the actual hormonal levels. And sometimes women have really high levels of estrogen in the perimenopause as well as really low levels. And that's why some women feel worse with HRT. And then something like the combined pill can be really helpful. So continuous HRT. So after someone has been 12 months without a period, starting these women on continuous HRT, often women won't be bleed free if their periods have only just stopped. It's much more likely if they've been stopped for a couple of years. If they've only just stopped, they're much more likely to have bleeding on HRT. So you might want to consider swapping these women back to a sequential regime. So if you've seen a patient, she's not had a period for a year, you've started her on continuous combined, you've reviewed her at 3 months, she's had 2 bleeds, you might want to think about, if it seems vaguely cyclical, going back to sequential. For the vast majority of these women, modifying their progestogen controls the bleeding, and again, the same as with sequential, changing the dose or the type of progestogen, but also thinking about reducing the dose of estrogen. So it's the estrogen that is stimulating the endometrium, is the progestogen that's working hard to thin that down and keep things stable. So often worth looking at that and seeing, do they actually need as much estrogen as they're on? And that's a really good reason to go slowly with estrogen when you're starting. So women in early perimenopause will often only need 1 pump of gel or a 25 microgram patch. If you've started someone on 2 pumps of gel, don't increase it until you see them at 3 months. 3 months is a really good time frame to allow symptoms to settle. And if you increase things too quickly, you can end up with a lot of estrogen on board that they can get side effects from, bloating, breast tenderness, anxiety, but it's also much more likely to increase their chance of bleeding, and they might not need all of that estrogen. So thinking about going slowly and dropping that dose. But also don't forget that you can get, as much as you can get atrophic vulvovaginitis, you can also get an atrophic endometrium. So if you've had someone who's bled and they've been scanned and they've got a very thin endometrium and you'd already made changes to their progestogen before they ended up going for a scan and you now don't know what to do, sometimes increasing their estrogen dose a little bit helps to reduce the atrophy of the endometrium. And don't forget vaginal estrogen. And just a little bit on estrogen doses. So you're probably all aware that there's been quite a lot of talk around estrogen doses because there are some cases where women have been prescribed very high doses. This is from the BMS document that I put on before, and it really clearly shows you all the different methods and what is classed as low dose, standard dose, moderate dose and high dose, and also allows you to see what you need to think about with progestogens in terms of making sure that you have got an adequate amount of progestogen for the dose of estrogen that you're prescribing. The most important thing to remember there really is that anything above a 75 microgram patch or 3 pumps of gel or 5 sprays of Lenzetto needs extra progesterone. And just to talk about the progestogens here, although we think about estrogen being the important part in VTE risk, progestogens play a part as well. So if you've got someone who has got an elevated VTE risk for whatever reason, then you need to think about the progestogen that you're using as well. So micronized progesterone is clot risk neutral. Combination patches with the progestogen through the skin is clot risk neutral, as are the 52 LNG coils. But things like Provera and norethisterone do come with a risk. So I've seen someone this morning in clinic who has had a PE and she is on estrogel, but she's on Provera with it because her bleeding wasn't managed, but she shouldn't really be on Provera because it carries too much of a risk for her. So just thinking about that as well, so you don't come unstuck with your progestogens. How much time have I got left? Okay, I'll be quick. So just very quickly touching on this, another thing which can lead to bleeding problems is absorption issues. When I say we're not that worried about the estrogen, obviously the whole point of HRT is to make someone feel better, and if they're not absorbing the estrogen, they're not going to, but it's not going to have a detrimental impact, whereas not absorbing the progestogen properly will. So we've all got absolutely loads of patients, haven't we, at the moment on the GLP-1 agonists, buying it privately. We don't always know. When I speak to women and say, have you changed anything medically? They say no, and actually they're on Mounjaro. They do impact on the absorption of oral progestogens, and the advice is for anyone on an oral progestogen that they need, well, ideally they would change to a non-oral, so a combination patch or a Mirena coil, or off license using micronized progesterone vaginally. The tricky time that we're worried about is 4 weeks after starting on weight loss injections and for 4 weeks after every dose increase. So because that happens quite frequently, it's hard to keep an eye on. Ideally, having these women on a non-oral progestogen is the best way to go with that. And just in case you've seen the FSRH guidance on contraception, the FSRH guidance, it only has concerns about Mounjaro, whereas there are concerns with HRT about all of the weight loss injections, and that's because if you were on a transdermal estrogen and an oral progestogen, you won't absorb as much of the oral progestogen, but you will carry on absorbing all of the estrogen, so it puts the endometrium at risk with all of the weight loss injections. Not forgetting about your enzyme inducers. Topiramate is often forgotten. It's a weak enzyme inducer. And then women who've had bariatric surgery. So just making sure that the progestogen you're giving them, they're able to absorb. Genitourinary symptoms, 50 to 70% of postmenopausal women will have these. Often it won't be something which starts early on in the menopause transition, although it can be, but lots of women will develop these symptoms in their late 60s, 70s. We all see them. Lots of old ladies in care homes with recurrent UTIs, women in their 60s repeatedly treating themselves for thrush or being treated by us for UTIs. Often it's as a result of low estrogen. Again, really important to examine these women and exclude other causes, particularly if they're giving you a bit of a strange story or if you've trialled some vaginal estrogen and it's not working. And that's because obviously there are other vulval dermatoses and infections, and they can really overlap. So lichen sclerosis, really common in this age group. Well, not really common, but most common in this age group. And lots of itchiness with that, lots of soreness, things that you could absolutely think are due to low estrogen. And there could be low estrogen playing a part in that as well, but obviously we want to treat it and improve their symptoms. not forgetting about STIs in this age group. So has been a rapid increase in STIs in women in midlife, and that's largely because sexual behaviours have changed, but also because people are quite complacent. They've potentially been in long-term relationships before, don't think about STIs, it doesn't cross their mind. And in the hub, since March, I've picked up 2 cases of trichomonas in people who were referred in with vaginal discharge and soreness, which had been being treated with vaginal estrogen. So that's not a criticism in any way, just to say we shouldn't forget about it, because these women are now feeling a lot better. Talking to women about vulval care, there's a really good leaflet on the British Association of Dermatology that you can text them. Moisturisers, but only yes, not Replens, it actually damages the tissues. And lubricants, yes, is a good brand as well. Vaginal estrogens, nearly everyone can have vaginal estrogen, even women who've had breast cancer. And the new updated NICE guidance that was released at the end of 2024 has got some really good decision aids in there, which are helpful for talking about risks of breast cancer, but also really helpful for talking about vaginal estrogen and taking you through, with women who've had breast cancer, who you need to be more worried about and who you can think about just getting on and prescribing. So the women that I would say don't prescribe in are women on aromatase inhibitors. You do need to discuss that with someone who's a menopause specialist or with their oncologist. But for everyone else, I'm not saying it's absolutely 100% safe, but the NICE guidance will take you through thinking about that. Some other good documents here. This is on the CliniBee app. That takes you through treatment. It's got all the different options of vaginal estrogens, and they are different. There are some that are estriol, there are some that are estradiol. Some women do better with one than another. There are some ultra low dose, so you've probably come across Blissell, which is a gel, and Invagis, which is a pessary. If you've got someone who is in their 60s or 70s, often they do much better with an ultra low dose, because you're introducing a much lower dose of estrogen that they're unlikely to have side effects with. Depending on where their symptoms are, is it mainly vaginal dryness, then a pessary might be better. If they've got lots of vulval symptoms, then some cream that they can apply directly. And if they've got lots of urethritis, again, being able to apply it directly can be really helpful. But that has a really good summary. And again, another document from the Primary Care Women's Health Society. Family history of breast cancer, I'll try and get through really quickly. The vast majority of breast cancers do not have a familial link. It's about 5%. Most women will have a relative who has had breast cancer, or lots of women will. So the vast majority of women are not going to be at risk because of their family history. The NICE guidance is absolutely brilliant on taking you through who you need to be concerned about. Women are split into low population risk, moderate increased risk, and high risk. The moderate and the high risk, if you identify them, need to be referred through to family history clinic before having an HRT discussion. Most moderate women can have HRT, high risk women not, because they're going to be going on a different treatment journey. But if you've got a woman in front of you who has got one first-degree relative who has been diagnosed over the age of 40 and no other relatives, she is going to be low population risk. So it's definitely worth going through that. And again, on this CliniBee app, which I have absolutely no investment in, it's just a good app. This genome, if you type into there, breast cancer risk, it helps you go through with the patient in front of you, just asking them questions, and then it comes out with a risk score for you. It would be really helpful before you refer through to either myself in the hub or to the menopause clinic at the Hallamshire to have identified, rather than just they've got a family history, it would be really helpful to have been through this and decided, are they at an increased risk? And if they are at an increased risk, referring them through to the family history clinic so that they've had that discussion, they're on enhanced surveillance, those sorts of things. And I probably haven't got any more time, have I, Tom? I was only going to talk about how young is too young, but okay, we'll do that quickly. So this was just to say that there are, obviously, there are women coming to see us younger and younger now asking about having HRT. But it is, and most women will be perimenopausal in their early to late 40s, sometimes later than that, but there will be women who are perimenopausal earlier on. So if you've got people in their late 30s, don't necessarily think that it absolutely isn't going to be perimenopause. So you can see in here that the vast majority are going to be in this usual age group for menopause of 45 to 55. You'll get outliers at either end, so those whose periods haven't stopped over 55, and you'll also get those with an early menopause between 40 and 44. And perimenopause, how long's a piece of string, but it can last between about 5 to 7 years. So if we expect that periods can stop naturally and we're not concerned about it, in that usual age group of 45, some of those women are going to be perimenopausal in their late 30s. And when we look at early menopause, then obviously they could be perimenopausal much earlier on. And the only way you're really going to know is by giving them a trial of HRT. And HRT, there is often a lot more caution about, but in this group of women, for the vast majority of them, we would give them the combined pill and have absolutely no qualms about it, and HRT is safer. So I'm not saying that we should be giving out HRT willy-nilly, but if you've done bloods to exclude other things, they've got a normal FSH, you're not thinking that this is, POI or something like that, then it's definitely worth a 3-month trial to see if they feel better, because some women will fall into that group. And sorry, I know I've really sped up towards the end, but just trying to pick up on those common things that are coming through and some bits that might be helpful for you. So thank you.
I would like a little bit of time to ask some questions, Lindsay, if that's all right, because this is hard stuff, isn't it? Let's get here straight away.
Just about the increase in thrombosis risk with progesterone. I wasn't aware of that because I thought progesterone in contraception is not high risk thrombosis, but you said that the microionized progesterone is better for thrombosis risk as well as.
So progesterone-only contraception doesn't come with an increased VTE risk, depot potentially in older women, but it's these separate progestogens that are sometimes used. So, when there were shortages of micronized progesterone a few years ago, lots of women were swapped to either Provera or norethisterone, and they, as an oral treatment, do come with a slightly increased VTE risk. Not dramatic, but in women that you are concerned about them having risk factors, I wouldn't use them. Transdermal's fine, yeah.
Hi, sorry, it's something I just didn't understand. You mentioned about if a woman has a scan and she's got an atrophic endometrium, you might want to increase the estrogen. Why is an atrophic endometrium a bad thing?
Because it might be causing them to bleed.
The atrophy.
Yeah.
Itself.
So someone once described it to me as though you get bleeding for 2 different reasons in the menopause. And one of them is that you've got, if you imagine paint on a wall, you've either got really thick paint that is dripping and bleeding, or you've got a really crumbly old wall that is bits of old paint are falling off. So that's not a very nice description, but that's why a thin endometrium might bleed.
Hi, so is the old advice of above 50, 1 year amenorrhea, below 50, 2 years amenorrhea now defunct, and is it just now 1 year amenorrhea they can start HRT?
To start continuous combined, or?
Sorry, yeah.
No, so it'd just be so that applies to contraception. The 2 years under 50 and 1 year over 50 would how we decide about whether women can stop contraception or not with their periods. But in terms of what type of HRT you go for, if you've got someone who's 49 and they've not had a period for a year, we would say that we would go for continuous combined.
Hi, I've just got a question about the patient who has had a total hysterectomy for a history of endometriosis. So we give combined HRT because we don't want to have unopposed estrogen for a theoretical ectopic endometrial tissue. What about the increased risk of breast cancer? Is there any guidance on that?
Yeah, so we know that there is a minimally increased risk of breast cancer with HRT. Potentially, some types of HRT are safer than others. NICE doesn't agree with that, but there is quite a lot of evidence out there to suggest that micronized progesterone and dydrogesterone that you get in Femiston are more breast friendly. But it's having that discussion with those women about the reasons that we are giving them progesterone, and if we could give estrogen only, that's great because it comes with little to no increased risk of breast cancer. But in those women, they've got a different disease process to someone who's had a hysterectomy for fibroids. So just having the same conversation that you would with someone who has got a uterus about breast cancer risks.
You talked about adding the combined, not forgetting the combined.
I can't
pill.
see where you are, sorry.
You talked about not using the combined pill perhaps to suppress endogenous cycle. Would you do that instead of HRT or on top of it?
No, absolutely instead. Sorry, I should have made that clear. Yeah. But the perimenopause, and you're probably finding this because women are coming younger and younger, actually they don't feel better with HRT necessarily, and you're messing about, changing lots of things. They might have irregular bleeding, and a lot of them feel a lot better if you can just quieten down the chaos that is going on with their own hormones. And you can do that with the combined pill, but some women don't want that or might have risk factors. So adding in a PARP alongside HRT can be really helpful. And you can, off license, use the new PARP SLIND, which is drospirenone, and that's a high enough dose to provide endometrial protection alongside estrogen, but it is off license.
Thank you.